Everyone for joining us today for our last seminar of 2025. Wow, the year's already wrapping up. We're very excited to have some excellent presenters today who will close out our year's discussion with a proverbial bang. And I look forward to a lively discussion. I also want to take a moment to thank everyone for their continued support of our work as we seek to highlight the amazing work being done on campus around public health and provide a space to celebrate our research faculty across campus. I hope everyone has a restful and safe holiday, and we will see you all back here again in the spring. But first, I'm very pleased to introduce our first speaker, Dr. Chanhyun Park. Dr. Park is a health outcomes researcher and assistant professor in the Health Outcomes Division at the UT College of Pharmacy. Before joining the University of Texas at Austin, she served as a health economist at the Centers for Disease Control and Prevention and as an assistant professor at Northeastern University School of Pharmacy. Her research seeks to assess clinical, economic, and humanistic outcomes of healthcare services and products using advanced quantitative methodologies. Using various methodologies, she aims to assess treatment patterns, identify potential adverse events, estimate healthcare utilization and costs, and improve health equity. Her current research program focuses on geriatric oncology and cardio oncology. So after Dr. Park gives her presentation, we will have about 5 to 10 minutes for anyone to ask any questions that they have. Feel free to type them into the chat box as well. Now, without further ado, please welcome Dr. Park.
Thank you for introduction, Dr. Brown, and good morning, everyone. So, can you hear me well? Good. Okay. So, I'm very honored to have this opportunity to present my recent research project, which I have titled Improving Cardiovascular Outcomes in Breast Cancer, a Machine Learning Approach. So here is an outline of my presentation today. In section 1, I will begin with a high-level overview of my building blocks of my research program. These are cardio-oncology, CL-linked data, and machine learning. And this section will help you understand my specific research project, which I will be presenting in section 2. So in section 2, I will introduce two of my ongoing projects, and I will talk about a project on predicting cause of death and predicting health-related quality of life among older women with breast cancer. So I would like to ask some questions throughout my presentation. So I would appreciate your any participation. So I will be using slido.com for those questions. So if possible, please go to slido.com using either your phone or your laptop and enter this event code PARK, P-A-R-K. Okay, so I hope you are ready. And so in this first section, I'm going to briefly introduce my building blocks of my research program. So I will ask this question about my therapeutic area. What is the description of cardio-oncology? So please go to slido.com and scan this QR code and submit your answer. Okay, thank you. So let me see the Richard. Yes. So cardio-oncology is focused on cardiovascular management of a patient with cancer. So cardio-oncology is an emerging field and multidisciplinary field. Many people still consider that cardiology and oncology are two separate fields, but actually cardiology and oncology are often closely intertwined. And they share some risk factors, and CBD can influence the development of cancer and vice versa. So let's explore this direction highlighted in pink. So there are several risk factors and underlying pathophysiological mechanism between cardiovascular disease, and cancer. So, for example, aging is a risk factor for both CVD and cancer. And there are also some modifiable shared risk factors such as smoking, obesity, and physical inactivity for both CVD and cancer. In addition to that, there are common underlying pathophysiological mechanisms such as chronic inflammations. So they are shared risk factors. And so now I want to look at this direction, highlighting in pink, focusing on the impact of CBD on cancer outcomes. And one of the study investigated whether cardiovascular disease is independently associated with the incidence of cancer. And they found that individuals with cardiovascular disease have an increased risk of developing different types of cancer compared to those without CVD. So we can say that CVD is a risk factor for cancer. But I want to look at the other direction here. And this cohort study investigated the effect of a new cancer diagnosis on the risk of cardiovascular event. And they found that a new cancer diagnosis is independently associated with the increased risk of cardiovascular morbidity and cardiovascular mortality as well, regardless of the cancer site. So cancer is a risk factor of CVD. So from cardio-oncology perspective, cancer can be categorized into those three groups. And this slide shows these three different types of graph, each showing the trend in CVD mortality and cancer mortality over past 4 decades for different types of cancer group. So in this first cancer group, such as lung cancer, cancer mortality rate has been consistently remained much higher than the CVD mortality rate. So in this second cancer group, such as kidney cancer, although cancer mortality rate has been decreasing, it still significantly exceeds the CVD mortality rate. And in the third group of cancer, cancer mortality rate has been substantially decreasing while CVD mortality rate has been increasing. So now they are similar to each other. And breast cancer falls into the third group where the prevention and management of CVD are very important. So later, I'm going to introduce my project regarding breast cancer. Okay, my second question. So I'm going to talk about my database. So I would like to hear your thoughts. Which disease does the SEER registry collect data on? Okay, let me move on. Yeah, that's about cancer. So I use SEER linked database a lot for most of my research programs. And SEER registry collect data on patient demographics and primary tumor site or tumor stage or like first course of treatment and cause of death. And this SEER data set can be linked with several different data sets, including Medicare enrollment and Medicare claims data, or Medicaid enrollment data without claims data, and MHOS data about health outcomes survey like health-related quality of life, and CAHPS data from consumer assessment of healthcare providers and systems. So later, I'm going to introduce my project using CR Medicare data and CR MHOS data. Okay, so my last question before moving on to machine learning. So did you happen to check your email this morning? Hey, yeah, probably most of you. So this means that if you answer yes, Machine learning saves your time by filtering spam emails from your inbox. So actually, machine learning is a subset of AI. And here, machine learning involves machines that automatically learn from data. So classical machine learning is often categorized into two types, supervised learning and unsupervised learning. The main difference between them is the use of labeled data. So in supervised learning, all data is labeled, and the machine learning algorithm learn to predict output based on those labeled input data. And in unsupervised learning, all data is unlabeled, and then those unsupervised machine learning algorithms learn to identify any patterns and any structures without labeled input data. So let me show you a simple example of using machine learning with this animal picture. So in supervised learning, we provide some animal pictures as input data, and these pictures are labeled if they are cats or non-cats. And the machine learns the rules to tell the difference between cats and non-cats. And a new picture is provided. The machine can tell if picture is a cat or not. So later, I'm going to introduce my project using this supervised machine learning. On the other hand, in unsupervised machine learning, we provide animal pictures as input data, but this time these are not labeled at all. And then machine try to figure out any patterns and any common things on those data by their own. And then machine divided data into a group without drawing labels. So many of you, and we already know that machine learning is great at making predictions. But here is my critical question about machine learning in my research program. That is machine learning good at predicting outcomes for really everyone? So what if these models are only accurate for the average Joe? What about like older adults or patients with multiple comorbidities or individuals in living in rural area with very limited healthcare access or like immigrants? So are these models just as reliable for them as well? So that was my fundamental research question, and that is my kind of fundamental issues that inform me my research question when I apply machine learning in health outcomes research. So now I would like to briefly introduce my ongoing project in cardio-oncology and machine learning using serial-linked data. So first, I would like to discuss our mortality prediction project. And the goal of this project was to develop machine learning models to predict all-cause mortality, breast cancer-related mortality, and CVD-related mortality among older women with early-stage breast cancer. And our specific objective are comparing predictive performance for each type of mortality between women aged 66 and 79 versus those aged 80 and older. And then we compared leading predictors between those two groups. So this is the summary of methodology. We use the Seer Medicare data to include older women with early stage breast cancer. And like I said, outcomes were three different types of mortality, and these are treated as time to event outcome. And we include various predictors like various socioeconomic characteristics and cancer-related factors and treatment-related factors, and a comprehensive set of 285 comorbidity types. And we used and we applied random survivor forest, which is one of the commonly used algorithm for survival data in machine learning. And we applied the SHAP approach to identify reading predictor. And SHAP is a widely used approach and explainable AI or interpreter of machine learning. So now I'm going to share some results. So this slide shows 10-year mortality outcomes. And as expected, compared to women aged 66 to 79, those aged 80 and older had significantly higher mortality rate, regardless of the type. But interestingly, the difference was a little bit greater for CVD mortality compared to cancer mortality. So this finding suggests us to look at two different age groups. And this slide shows about predictive performance. And we found that our models showed good to excellent predictive performance. But interestingly, the predictive performance was lower in the 80 plus group compared to 66, 79 groups. And this slide shows the reading predictor of all-cause mortality for those two age group. And commonly, older age, lack of screening, and heart failure were key predictor for both age group. But very interestingly, cognitive disorders was a key predictor only in the 80 and older group. This is about cancer-related mortality. As expected, cancer-related factors were significant in both groups. But interestingly, we found that age, so getting older, is emerged as a key predictor only in the age plus group, only in the 80 plus group. And then this slide shows about reading predictors of CVD-related mortality. And we found that heart failure, age were important predictors for both groups, but cardiomyopathy was key predictor in the 66 to 79 age group, while acute cerebrovascular disease emerged as a key predictors in the 80 plus group. So based on those findings, we concluded that our models demonstrated strong predictive performance, but performance was relatively lower in the 80 plus age group compared to younger counterparts. And the predictors of all-cause breast cancer and CVD-related mortality are a little bit different between two age groups. So we think that implementing geriatric-focused cardio-oncology care is important to address unique need of this oldest old population, and maybe tailored interventions are needed to manage those specific mortality risk factor prevalent in oldest old age group. So that was the first project. And I'm going to briefly go over the second project about health-related quality of life predictions. So this project was about to develop machine learning models to predict health-related quality of life in older women with early stage breast cancer. Like previous project, our objective was to compare predictive performance of health-related quality of life with women with cardiovascular disease versus women without cardiovascular disease. And we also compare leading predictors of physical and mental health related quality of life of those two groups. And this slide shows methodology summary. So we used CR-MHOS data to include older women with early stage breast cancer. And our outcomes are health-related quality of life, including both physical component, PCS, and mental component, MCS. And we included various predictors like individual, socioeconomic, cancer-related, treatment-related predictors. And we also include area-level social determinant of health predictors. And for this project, we used four different types of tree-based algorithm, which are commonly used machine learning algorithm in health outcomes research. We also applied the shape approach to identify the reading predictors. And then, so among older women with breast cancer, about 9% had angina and 6% had heart failure or myocardial infarctions. And as you can see here, orange bar, those older women with cardiovascular disease had significantly lower physical and mental health related quality of life score compared to blue bars, those without those comorbidities. And then we compared the predictive performance for both physical and mental health related quality of life score based on the presence and absence of cardiovascular disease. And we found that all models showed acceptable predictive performance, but the performance was a little bit lower among those with CBD compared to without CBD. And we identified some leading predictors for both physical and mental health-related quality of life by the presence of different types of CBD using explainable AI approach. So I'm not going to talk about those details of those figures, but this is the summary of our finding. So regardless of the presence of CBD, obesity was the most important factor for predicting physical health related quality of life. And low income was the most important factor for predicting mental health related quality of life. So among women with cardiovascular disease, so CBD itself was an important predictors for both physical and mental health related quality of life. And interestingly, home ownership emerged as an important factor for both physical and mental health related quality of life among those without CBD. So here is the conclusion. All models demonstrated acceptable, like predictable performance, although those performance was a little bit lower among women with cardiovascular disease versus without cardiovascular disease. And the leading predictors of health-related quality of life were a little bit different between those two groups without cardiovascular disease. And we found that socioeconomic status was an important factor for mental health-related quality of life. So maybe tailored strategy should address both obesity for physical health related quality of life and socioeconomic factors for mental health related quality of life to improve those health related quality of life, considering differences by cardiovascular disease status. And yeah, and that is all I prepared. And now I am open to the floor for any questions. And this is my email address. So if you have any questions or concern about suggestion about my project, feel free to reach out to me. And also, if you are interested in collaborating with me and our group, please reach out to me as well. Yeah, that's all.
Wow. Very fascinating, Dr. Park. I did not see that home ownership one coming at all.
Uh-huh. Yeah, I thought that that's very interesting because, I mean, in general, social determinant of health is very important factors for their mental health related quality of life. I mean, so yeah, I think we should consider that when we work with our patients beyond just data set.
Yeah, and it's going to be fascinating going forward because of how much harder it's becoming to own a home, I'm
Oh
guessing.
yeah. Yeah, especially these days in Austin.
Exactly.
Yeah.
Thank you very much. Any other questions for Dr. Park? All right. Thank you so much, Dr. Park.
Yeah, thank you for inviting me. Yeah.
And next, we have Dr. Andreana Haley. Dr. Haley is the Charles Shea Regents Professor in Clinical Psychology and Director of Clinical Training within the College of Liberal Arts Department of Psychology. Her research examines the biological underpinnings of cognitive impairments associated with aging and dementia. As a clinical neuropsychologist, she is interested in the neural substrates of memory, language, and executive function in clinical populations in vivo by utilizing functional neuroimaging and spectroscopy. She also conducts work to determine how disturbances in glucose metabolism, hormonal regulation, and cardiovascular functioning contribute to changes in cognition, brain morphology, and energy metabolism. Her goal is to bridge knowledge from basic and clinical neuroscience with the aim of improving how we understand, predict, and treat age and disease-related cognitive impairment. Please welcome Dr. Haley.
Thank you, Jay. Thank you all for inviting me and for enduring here at the end of the semester. I am hoping for collaborators, so please listen with that in mind to see if there's anything we can do together. This talk, I think I got invited because of a paper we published last year that was a midlife intervention study targeting the liver and hoping for brain effects. Which was pretty exciting. And so this talk is also lovingly called "Why the Brain Needs a Liver," but it is about diet, metabolism, and brain health. And I'm hoping to convince you why those things are important. Okay, let's see. So I have a clinical neuroscience lab. We always, for decades, scanned brains only, and we cared mostly about cognition, some about mood, but mostly about brain. And through decades of work, we got led to the body and especially to the liver. So this is my lab being super excited to produce a liver image for the first time. So the point of this, the three questions that I will discuss today are: how does metabolic dysfunction signal early brain vulnerability? Can we identify specific mechanisms that can be targets for intervention? And can an intervention aimed at supporting liver health rescue the brain as well? And obviously, a lot of people were involved in the study. It's an intervention study, including body and brain imaging. But the people listed on the left: my graduate student, Isabel, my postdoc, Marie, my coordinator, Jessica, and a collaborating labs graduate student, Tianyu Wang, who is now a PhD, were very instrumental in completing this work. We are very interested in midlife. Generally, I'm trained as a geriatric neuropsychologist to assess brain function at end of life or older age. But throughout our work, we have discovered that when you have Alzheimer's disease or vascular dementia already clinically symptomatic, it's way too late to intervene. And we're not the only ones who have arrived at this conclusion. The field has moved very much towards early intervention, early detection. And this figure is everywhere. It's published by the Lancet Commission on Dementia Prevention, Intervention, and Care. This is the 2024 update. And what the figure is basically telling us is that 45% of the risk for dementia is potentially modifiable. And a lot of that risk accumulates at midlife. So midlife metabolic health, like high cholesterol, diabetes, hypertension, obesity, is a potential place where we could intervene in order to reduce dementia risk. And I don't need to convince you that dementia is a problem. We just voted as a state to create a fund to support work on dementia research. So I don't need to convince you that it is a global challenge, and we are trying to tackle it from a lot of different directions. The way my lab, which is a clinical neuroscience lab, landed on the liver is that we are generally interested in all risk factors that would impact the brain early. And that includes disease like liver disease, cardiovascular disease, lifestyle factors like inactivity or poor diet, genetics, air pollution is a new part that we have added to the stuff that we are interested in. But for many years, we tended to focus on unhealthy lipids, high blood pressure, high blood sugar, and obesity, or when you have three or more of the above, the so-called metabolic syndrome. So we published a lot of papers identifying various markers in the brain that are potential markers of vulnerability associated with metabolic syndrome and potentially pointing towards developing cognitive impairment later in life. So a lot of papers were correlational, kind of a lot of hand waving, look at this correlation, blah, blah. Every paper ended with someone should do something about it. Someone should do something about it. And we decided that finally we probably should be one of the labs that should try to do something about it. So we were considering kind of the dual pathways of cognitive decline, which were classic and way back when we are taught in school that there's one pathway that kind of moves from anterior to posterior, impacts the frontal lobes first, vascular potentially an origin, hitting the white matter, coming out with attention executive impairments. On the other hand, there's another pathway that kind of starts in the medial temporal lobe, goes in the other direction, posterior to anterior, possibly hitting some kind of neurodegenerative changes, starting in the hippocampus, amnestic memory impairment being the focus, the clinical symptom, and then eventually both of these pathways collide and you have dementia. More recently, however, we have discovered, the field in general, not me personally, that these factors are deeply intertwined, that they share upstream metabolic risks, vascular and glial networks share metabolic signaling pathways, astrocytes bridge neuronal and endothelial health, and it is not so easy to cleanly separate these dual pathways. So in a lot of our work, the pilot work or the work that led to the current study is based on about 500 community dwelling adults, ages 40 to 60, so midlife. They're free of overt cardiovascular, neurological, psychiatric disease, and MRI contraindications. So for all intents and purposes, these are healthy people, and their cognitive status is unimpaired. We use a screener, the mini mental status exam. The screener for cognitive impairment, the cutoff is 24. Our sample is very healthy. The average MMSE is about 27, so definitely cognitively unimpaired. They come in, they do a visit where they do a health screen. We do vascular measures of health. We do biomarkers. We do height and weight, obesity measurements, visceral fat. Then they do a second visit, a full cognitive eval, and then a third visit where they get a lot of different neuroimaging markers. So for health, we do glycemic control, lipid profile, inflammation, all the things we need to establish metabolic syndrome. We also, with the ultrasound measures, we get arterial stiffness, endothelial function, atherosclerosis. On the cognitive front, we have measures of learning, recall, and recognition. Executive function, we measure verbal fluency, working memory, task switching, and flexibility. And in terms of brain markers, as said, we have a lot of different measures. We get neurochemistry. I'm particularly interested in glutamate, the main excitatory neurotransmitter, and myoinositol, which is an organic osmolyte and also potentially a marker of inflammation in the brain. Functional brain networks, we could measure them at rest and look at kind of network coherence, how strong the correlations are within each network, or segregation. Are those networks segregated, or are they getting intercorrelated or desegregated, which is the desegregation of functional network is a marker of aging and kind of cognitive impairment. And we can also measure physiological blood perfusion in the brain. So a lot of different physiological markers of brain function. So in the early work, we found that metabolic syndrome is related to poorer cognitive function. And remind you, these are healthy people in midlife. So zero, this is on a y-axis on the left graph, we have memory domain z-score. So 0 is the average person. On the x-axis, we have yes, no metabolic syndrome. And you can see that even in the cognitively unimpaired, the people without metabolic syndrome are performing about half a standard deviation better than those with metabolic syndrome. And at the same time, metabolic syndrome is related to decrease in the functional coherence of brain networks, sort of the within network correlations. Same idea. This is a Fisher-Z network metric for coherence. The people with metabolic syndrome seem to have much lower within network coherence. In terms of neurochemistry, this is the excitatory neurotransmitter glutamate, which we absolutely need for any cognitive function. The point with glutamate, though, is that it needs to cycle efficiently. It needs to come out when it's needed, and it needs to be reabsorbed when it's not needed immediately. When it lingers in the intercellular space, it tends to create this neurotoxic environment where you are causing excitotoxicity in the following neurons. So we don't want glutamate freely accumulating in the intercellular space. So what we see here is that glutamate is accumulating in the people with metabolic syndrome. Even though they're cognitively normal in midlife, we are creating an environment that is potentially problematic for the brain. Myoinositol at the same time is seen to increase in asymptomatic Alzheimer's disease and mild cognitive impairment. And here we are seeing myoinositol creep up in the people with metabolic syndrome as well. In terms of the early vascular functions work, we see a lot of metabolic syndrome brain, age, sex, brain associations in that. Here it is on the first graph. Increase in subclinical atherosclerosis tends to exacerbate this potential neurotoxicity in the brain that we see in metabolic syndrome. So you have metabolic syndrome, IMT, the subclinical atherosclerosis estimated by ultrasound, tends to be an independent risk factor for vascular disease. And we see if you have two of those hits, you tend to do worse. In terms of frontal white matter perfusion, so this is just literally a physiological perfusion marker, we see that arterial stiffness measured by pulse wave velocity, this is an ultrasound measure of arterial stiffness, increased arterial stiffness is related to poorer front matter, white matter perfusion. And then the same and on the last graph, we see these kind of complicated age, sex, brain associations where white matter integrity in one of the big bundles, the cingulum bundle, is related. Poorer white matter integrity is related to higher arterial stiffness in the men, but not in the women. And mind you, we are at midlife, right where women are crossing into menopause. So it points towards having to look a little bit more deeply into what is going on in women's health, because women have a higher risk for Alzheimer's disease. And here we are seeing these kind of complicated interactions between arterial stiffness and white matter health in men versus women. So what about metabolic syndrome is bad for the brain exactly? It could be visceral adiposity, dyslipidemia, hypertension, vascular disease, hyperglycemia, insulin sensitivity, any and all of the above. And if you look at the literature, all of them have been implicated in poorer brain function. In our work, visceral adiposity just tended to pull and pull and pull. So even though we went in there thinking, well, metabolic syndrome is probably more than the sum of its components, it seems like there's something special about visceral adiposity that's particularly bad for the brain. So then you start wondering, well, what exactly about visceral adiposity is bad for the brain? And you read the literature and you see inflammation, oxidative damage, cellular signaling, processing, apoptosis. And all of these are very broad, very non-specific mechanisms and not exactly ready for an intervention. They're a little bit like inflammation, pain, redness, fever. It's non-specific. Like I don't know where to intervene when I see these non-specific markers. So that is how we as a neuroscience lab arrived at the liver. The liver, everyone knows that when your liver fails, you get hepatic encephalopathy, no questions asked. But the point is that the liver is very important for cognitive function, even very early on in the onset of disease, even before people know that fat is even accumulating in their liver. So, and more importantly, we have a specific mechanisms that we have outcomes for that we can monitor. So liver disease disrupts the glutamate nitric oxide CGMP pathway. In the inefficient glutamate astrocyte cycling, you have a balanced nitrous oxide CGMP signaling, subtle, stable extracellular glutamate, and intact learning and executive function. On the other hand, when fat starts accumulating in the liver, it disrupts glutamate clearance, reduces nitrous oxide cGMP synthesis, increases extracellular glutamate, which is the glutamate we can measure with magnetic resonance spectroscopy, and reduces learning and executive efficiency. So now we have an actual mechanism that we can try to intervene on. And then the question at hand was, well, how? Like, what's out there that can possibly budge this mechanism? Can we intervention aimed at liver health rescue the brain? And what would that intervention look like? So when you look around, these are interventions just to treat fatty liver. And we found this paper that was published in 2011 by, this was data from the Dallas Heart Study, so it's our own Texan data. 2 weeks of dieting, small sample, 18 participants, but they showed that low calorie and low carb diets dropped both weight and hepatic triglycerides, so the fatty substances accumulating in the liver, very efficiently, very quickly. So we thought, okay, let's do a proof of concept and see. We know this diet can drop the fatty liver. Can we actually get the brain to respond? And the brain is extraordinarily it has a very strong autonomic control. Like, it's very hard to budge the brain by kind of, pushing on the outside. So what we did is we took people in midlife. We wanted them to have fatty liver because this is a proof of concept and we didn't have time to mess around with controls. But fatty liver is very hard. It's asymptomatic. People don't know they have it. We asked for people with metabolic syndrome or non-muscled, and still out of 55, 11 didn't have it. So 44 people entered the study with actual fatty liver disease, and the clinical criterion for fatty liver is 5% triglycerides in the liver. So there is a clinical cutoff, and we can do that with magnetic resonance spectroscopy. We can measure the content and have a clinical criterion. Then we put them in a 2-week low calorie or low carbohydrate diet. We delivered all food, so it was cooked by a commercial kitchen and delivered to their door. So all they had to do is only eat that. The outcomes, the main outcomes were hepatic triglycerides and liver and cerebral glutamate. And then we measured all of these secondary outcomes just to see what happens: metabolic parameters, vascular function, functional brain networks. So lo and behold, diet intervention significantly reduced liver fat and muscle, which is what we were starting with. This is replicating the data from the Dallas Heart Study. So within 2 weeks, liver triglycerides, this is measured by proton density fat fraction, measured by MRS, dropped by 18%. So this was expected. We were banking on it. What was exciting is that within 2 weeks, the brain also responded in the accepted direction. So glutamate and myoinositol in the brain dropped by 6 to 7%. And the concentrations of these chemicals in the brain is very small. So 6 to 7% drop is a significant change in brain chemistry. And then you look at the secondary outcomes. So what happened to the metabolic parameters? What happened to vascular function? And everything improved within 2 weeks. Systolic blood pressure dropped, diastolic blood pressure dropped, insulin sensitivity got improved, inflammation got improved, visceral fat got improved. So we have a 5% drop in blood pressure, 18% improvement in insulin sensitivity, 5% improvement in inflammation, and 3% improvement in visceral fat. In terms of arterial stiffness and endothelial function, muscled are the people that we were targeting. And we see an improvement in pulse wave velocity, and we see an improvement in flow-mediated vasodilation. So pulse wave velocity was stiffness, so we want less stiffness, right? And flow-mediated vasodilation is actual endothelial function, so we wanted to get better, and it did post-intervention for the people who have identified liver disease. The other people didn't respond. And in the brain, this first part of the graph kind of repeats the findings you just saw. Hepatic triglyceride dropped in the liver, glutamate and myoinositol dropped in the brain. At the same time, network segregation improved. So also, this is a second marker of brain function that moved in the accepted direction. It got improved by 11%. So remember, with aging, I said when these systems desegregate, we tend to have poorer cognitive function with aging. So here, they were more desegregated pre-treatment and more segregated post-treatment, which in this case, we want these systems functioning separately and efficiently. In this case, is a good thing. On the other hand, cerebral blood flow did not change in the people with or without liver disease. So there was no significant change in total brain perfusion. So what about adiposity is bad for the brain? This is a model that was published in 22 that said liver steatosis, or fatty accumulation deposits in the liver, damage endothelial function, create atherosclerosis, inflammation, ultimately damaging, causing neuroinflammation and causing cerebrovascular injury. So what did we see in our data? We saw that muscle actually definitely impacts all of these pathways that were in the model, except we can now add they are movable. So that these relationships are bidirectional, and if you catch this disease early on, you can improve all of these parameters. We saw that dropping liver fat improved endothelial function, dropping liver fat improved arterial stiffness, dropping liver fat improved inflammation. What was good is that we actually did not see cerebrovascular injury. Perfusion was normal. So to me, that's positive. So if we catch this disease early enough before we have vascular injury and reverse all of these pathways, we have a chance of saving the liver and the brain. And what we did see is glutamate dysregulation, potential neurotoxicity, but again, reversible at this stage of disease. So we're super excited about these results because we have so few things that we can offer to people to prevent brain and cognitive disorder. So this was extremely exciting to us, and that's how we got in the UT Health newsletter, and that's how we got invited here. I just want to acknowledge that this was a lot of work done by my lab, the Clinical Neuroscience Lab, in collaboration with Cardiovascular Aging Lab led by Dr. Hiro Tanaka, and in collaboration with Children's Healthcare of Atlanta, our neurospectroscopist, Jack Knight-Scott. And the study was funded by the University of Texas. The preliminary data that you saw were funded by NANDS, Darrell K. Royale, and the National Institute on Aging. And thank you very much for your attention, and I'm looking forward to chatting.
Excellent work, Andreana. Any questions for Dr. Haley? Well, it seems like you did a great job of explaining everything, even though it was very complicated at times. I think it's some groundbreaking stuff in how we look at CBD going forward. So,
Well, if we don't have questions for me, can I ask a question of Dr. Park?
sure.
I was very interested in your work. Thank you for presenting it. And my question was that I think we know that some of the treatments for cancer are related to increased risk for cardiovascular disease. And I was wondering if you can comment on sort of how much of this is the cancer itself, how much of it is the treatment? Can we separate these?
Yeah, so I think it's a very good question because based on previous literature, and I feel like cancer itself can increase the risk of cardiovascular disease. But more importantly, there are so many different types of medications like cancer treatment that leads to cardiac toxicity. So because of both like cancer itself and cancer treatment increase the risk of cardiovascular disease among cancer survivors. Yeah, I think it's a great question because like anthracyclines, which is very commonly used for various cancer treatment, and HER2 targeted therapy like trastuzumab cause different types of cardiovascular disease as well. So I'm currently working on both like cancer itself and like treatment related cardiac toxicity.
Thank you. Yes, I was very interested in the oldest old findings, and
Hmm.
maybe if your models can do a better prediction, maybe the recommendation would be to treat the oldest old a little bit more conservatively with less chemotherapy if they're more likely to die of cardiovascular disease than they are of the cancer itself.
Right, right. Because I mean, their health status is very, I mean, each individual's health status is very different, especially for those oldest old population. Yeah, I think that's a great point. And thank you for your comments.
Thank you.
Thank you both so much today, Dr. Park and Dr. Haley. And thank you all for coming today. And Kyle, want to take us away?
Sure. Yeah. Thanks so much again for joining everybody. Today was, as Jay said, our last session for this year, but we will be coming back next semester. So keep an eye out for more updates on speakers and dates next semester. Thanks, guys. Appreciate it. Have a great
Happy
holiday,
holidays.
everybody. Take care.